to the technical.
Excuse me. I've not been assigned as an interpreter. I'm the Portuguese interpreter.
It has been done now.
I'm not assigned yet.
It's been done now.
Sorry, not yet.
You can just go on. It will come through now.
Okay, we'll jump in and hopefully Portuguese will be available momentarily. You can choose French or Portuguese. You can see the little icon at the bottom where it says interpretation. So hopefully it looks like those are all functional now. Let us know in the chat if you're having any issues. So welcome everyone. If you can put in your name and your country where you're calling in from so we know who's in our room. And welcome to the technical guidance update on priority populations. We have an exciting list of presentations and speakers from our Office of HIV/AIDS. Any questions, please put them into the chat. We may be able to respond as we go in the chat box, but at the end, we have a good amount of time for question and answer among all the presenters. And we really look forward to questions that come in and a chance to discuss after these presentations. So please, we encourage you to put all your thoughts into the chat and share your questions with us as we go. So I will turn it over to Colette Peck from our Office of HIV/AIDS to start us off.
Great. Thanks very much, Debbie. Good morning, good afternoon, everyone. Really happy to be here with you today. As Debbie said, I'm Colette Peck, and I'm a Senior Orphans and Vulnerable Children Advisor in the Office of HIV/AIDS, and just going to go over some of our technical kind of guidance and updates with you here. So thanks, got the first slide going. So OVC funding serves a dual purpose of both mitigating the impact of HIV and AIDS on children and adolescents, as well as addressing the prevention of HIV and AIDS related morbidity and mortality, as well as infection. As you may know, we have three kind of models we talk about that all contribute to OVC serve results. First here is OVC preventive. This programming is really a group-based approach that is aimed at preventing HIV and violence amongst girls and boys aged 9 to 14 in high-burden districts. This is based just on the delivery of an intervention and reported accordingly. We then have DREAMS, which of course is a different program, and we'll hear more about that. But which contributes to, is reported under OVC serve as part of AGYW PREV results at an OU level. And then we have OVC comprehensive, which is really kind of the heart of our OVC programming. It's aimed at children under 18 and their families with known risk factors. It's based on a family-based approach and needs-based interventions through case management. It's reported through OVC serve and OVC HIV stat, and it's measured through graduation benchmarks. And I'll talk a little bit, we're going to go a little bit more into this bucket of the program. Next slide, please. So we don't really like to say OVC package of services, since this comprehensive program is not a one-size-fits-all approach. It's tailored to identified needs that are addressed through a case management model and case planning. In the context of OVC programming, case management is the process of identifying, assessing, planning, referring, and tracking referrals, and monitoring the delivery of services in a timely, context-sensitive, individualized, and family-centered manner to achieve specific goals around health and well-being. Although we count individuals in reporting and our indicators, our case management and graduation under the comprehensive model are done at a family and household level. And minimum graduation benchmarks have been established to ensure that PEPFAR programs have aligned objectives for progressing children and their caregivers to a minimum level of stability. So a household enrolled in a PEPFAR OVC program graduates when the children and caregivers are deemed to have become more stable and no longer in need of project provided services. And our graduation benchmarks are purposefully set at a high standard for children and caregivers to graduate from the program in a stable situation, with their well-being measured over our kind of 4 umbrella domains of healthy, safe, stable, and schooled. Next slide, please. So here we have, we referenced the OVC Balancing Act, knowing that we are kind of always balancing these different mitigation, care, and prevention priorities. We are focused on offering enrollment in the OVC program to prioritize subgroups that are listed here, notably CLHIV, CNAL HIV under 18 that are on ART, and children with known risk factors, as well as, again, that 9 to 14 age set for OVC preventive. There are, in different OUs, there are sometimes adaptations to these priority subpopulations based on context. Next slide, please. So we are referencing some of the language that's from the COP guidance here, although these are all directives we expect to be the same in COP22 and that we continue to program around. So the guidance has stated that where OVC and pediatric treatment programs geographically overlap, children living with HIV should be offered enrollment in OVC programs. In high volume clinics within high burden SNUs, at least 90% of children under 19 in PEPFAR supported treatment sites should be offered enrollment in OVC programs. And OVC staff placed in clinics should have the capacity to assess child and family needs and to offer appropriate referrals. So that continues that coverage of enrollment of CLHIV under 18 in our OVC program continues to be a high priority. We want to continue to build on the fantastic successes pediatric and OVC partners have achieved through working closely together, many of which I know were just highlighted in the excellent OVC local partner panel. And 4 of our PEDS and OVC technical priorities are listed here, including supporting pediatric index testing, as I mentioned, offering enrollment of CLHIV, supporting positive children and their parents and addressing the barriers to care, and improving viral load coverage and suppression. Next slide, please. So I won't read through all of this, but across the cascade, there are lots of opportunities for clinical and OVC multidisciplinary teams to address barriers and support case finding, especially through offering testing and index testing, offering enrollment into the OVC program, ensuring linkage to treatment, continuity of treatment, and viral suppression. We've also found that having IPs train each other, clinical and community IPs, has been a successful strategy to help ensure multidisciplinary teams are capacitated and strengthened to provide necessary and complementary support to help C and ALHIV and their families reach their health goals. So some specific examples here kind of across the 95s. Next slide, please. And we also want to encourage OVC clinical and key population IPs to work closely together, where children of key pop subgroups, such as children of female sex workers, are prioritized to ensure that children of KP and their families are engaged in critical health, psychosocial, and economic strengthening interventions. Mentioned here, for example, in Tanzania, USAID's Kizazi Kipya OVC program has a differentiated service delivery approach tailored for children of FSW. Which includes linkage of at-risk children, HIV testing, treatment and care services, and support services such as child protection and nutrition assessments. Next slide, please. So I know this is FY20 data presented here, but just a few examples, and we fortunately have more and more all the time, as this is now more standard OVC PEDS practice, is OVC programs and their role in tracking and monitoring viral load suppression among CLHIV. And the couple of examples here, nice ones that we had from Malawi and Nigeria, where strategies have been implemented to improve viral load suppression among CLHIV, and have found that suppression for those enrolled in OVC or in a geographic area with an OVC program have a higher viral load suppression rate than those not supported by OVC. Next slide. This is just a bit more detail on the OVC preventive model, including the approved curricula. So again, this is kind of that first bucket that I noted earlier. It's important to note that facilitators in OVC preventive programming should be trained in handling disclosure of HIV status and experience of sexual violence in that setting, and that appropriate referral protocols and reporting procedures are in place. We also want to make sure that there are strong referrals in place between the OVC preventive programming should children be identified there who need to be referred into the comprehensive program because they fall into a high-risk group. Next slide, please. Just a quick note, we continue, and I know we'll hear more about DREAMS here. We continue to encourage really close coordination between OVC and DREAMS programming around target setting and really, most importantly, around effectively meeting the unique needs of AGYW between 10 and 17 that kind of fall within the target age bands of both programs. We know that there may be certain needs that can be met by the OVC or the DREAMS program. Next slide, please. And finally, a couple of just quick notes on MER updates. There are no changes to OVC Serve, which is our primary indicator. So nothing has changed there. It's still as it appears here in the updated MER guidance. And then on the next slide, there are just a few changes to OVC HIV stat. The age and sex disaggregates are thereby, as listed in the pictures here, to allow for more precise monitoring of our comprehensive program results and our coverage. And there's some language that has been added as well around encouraging clinical confirmation of HIV or ART status wherever possible. And I know a number of programs have really made great strides in doing that. Next slide, please. And just a quick reminder that also over the last year, we've rolled out these USAID OVC Custom Indicators, which supplement our MER indicators and have been providing us some great additional data to track some of our key technical priorities. These are USAID only and are designed to align with the clinical cascade to provide some more data on our OVC contributions to testing and viral load suppression, among other areas. And around the offer and enroll, as that is a specific mandate in the COP guidance. Next slide. And finally, just a few resources listed here. Obviously, the COP22 guidance will be coming soon. There are some fabulous resources around our pediatric collaboration and support. Hopefully, many of you have already seen these. There was an excellent webinar recently on the toolkit that's available around pediatric index testing. We also have some USAID PDTG rollout resources, particularly how OVC programming and caseworkers can support this, and an excellent suite of tools around supporting MMD for C and AL HIV. I don't think, sorry, I have the link in there, but we can make sure that they are shared, violence against children prevention and response resources as well. And I believe that will be touched on in the gender section. But next slide, I think that takes me to the end there. So thanks very much. Please do add any questions into the chat and I will hand over to the next presenter.
Great, thank you very much, Colette. Hello, good morning and good afternoon. My name is Kieran King and I'm the program analyst on the youth branch at OHA. And today I'm going to provide you with some updates regarding our DREAMS programming. So DREAMS is PEPFAR's flagship HIV prevention program targeting adolescent girls and young women, who we often refer to as AGYW, ages 10 to 24 years old. It was announced by Ambassador Birx on World AIDS Day in 2014 and has evolved from a 2-year centrally funded partnership in select high-burden geographic areas in 10 countries to the standard PEPFAR HIV prevention approach that's now implemented in 15 countries in sub-Saharan Africa, as well as Haiti. Next slide, please. DREAMS strives to reach AGYW at greatest risk of HIV acquisition in the highest burden districts where PEPFAR works. Thus, in addition to determining the most appropriate interventions for a given country context, Each country program determines risk factors and vulnerability criteria for participation in the DREAMS program based on the local context and the latest evidence in line with PEPFAR guidance. AGYW meeting any one of these factors of criteria are eligible for enrollment into the DREAMS program. Some examples of these include history of pregnancy, exposure to violence, STIs, and engagement in transactional sex. A fundamental principle of DREAMS is the layering of evidence-based programs and services to ensure that the complex needs of adolescent girls and young women are met. The principle of layering is based on positive youth development research showing that comprehensive care is more effective than standalone services. In this diagram, you can see that DREAMS funds a core package of evidence-informed approaches that go beyond the health sector, addressing the structural drivers that directly or indirectly increase girls' HIV risk, which includes poverty, gender inequality, sexual violence, and a lack of education. The core package of interventions addresses HIV prevention for the most vulnerable AGYW through working with 4 overlapping populations, including AGYW themselves, their families, their male sexual partners, and their larger communities. So now I'd like to highlight a few new and anticipated enhancements to the DREAMS program. A comprehensive economic strengthening package will be implemented in DREAMS programming across DREAMS districts this fiscal year. As a primary prevention, HQ recommends a basic package of financial literacy training offered to all age bands in DREAMS. However, a comprehensive package was rolled out beginning last fiscal year as a secondary service for all out-of-school 15 to 19-year-olds and all those in the 20 to 24 age band. Elements of a comprehensive economic strengthening package include a market assessment, gender-specific training, startup support post-training, savings groups, and facilitated access to social and business networks, coaching, or mentoring. USAID has also rolled out custom indicators to better capture some of the nuances of our programming, meet the demands of our ever-evolving program needs, advance analytical products for planning, better focus program monitoring activities, and enhance advocacy for innovative program approaches and solutions. While the DREAMS FP indicator is new to fiscal year 21, the initial reports show that there is real opportunity and need among DREAMS participants. Results show that implants, injectables, and OCPs are the most commonly requested and provided forms of contraception for AGYW enrolled in DREAMS. There may be a particular opportunity for USAID and PEPFAR to provide technical assistance to further support family planning services in OUs. Kenya and Malawi are showing the highest overall total results for DREAMS family planning. And our second custom indicator includes DREAMS Gen Norm. Results of this indicator through fiscal year 21 quarter 3 suggest that we are primarily reaching AGYW. However, the component of this package is intended to also reach men and boys and mobilize the broader community. This may be a result of underreporting on community-based normative change activities, so the Gender and Sexual Diversity branch, as well as the Youth branch, are collaborating to improve data and program quality around this indicator. The COVID pandemic has disrupted health and social services worldwide, with particular impacts to our prevention programming. Specifically, DREAMS relies on Safe Spaces platform and other means of connecting in person and in group settings, and lockdowns have really impacted entry points such as schools. While programs are innovating and adapting, the continued impact remains to be determined, especially in the context of many OUs facing third waves of lockdown, such as Uganda, Namibia, and Zambia. Efforts by mentors and peer educators to stay connected with the AGYW participants becomes more challenging and has required a redoubled of efforts to maintain those connections. PEPFAR has regularly issued COVID-specific guidance for continuity of programming and addressing the frequently identified challenges and solutions. And here on this slide, you can see a lot of the challenges most of our OUs are facing and the modifications that they have made to adapt. PEPFAR COP guidance for COP21 and 22 highlights some key technical priorities which USAID has been supporting in our DREAMS program implementation and planning. I've already highlighted some of the primary priorities related to ensuring the highest risk participants are identified and enrolled, and that they complete in an evidence-based core package of services delivered with quality and fidelity. To balance a positive youth development approach with AGYW needs, closer monitoring of time and DREAMS program and planning for program completion will be captured with the newly designed layering table. Economic strengthening interventions continue to be a priority across DREAMS OUs, including employing DREAMS ambassadors who can provide mentorship, guidance, and assist with the PrEP demand creation. Parenting interventions will also remain a secondary service for COP21. Looking ahead, we continue to build upon the PEPFAR strategy and continue to innovate our programs. It's important to recognize that many of the factors that contribute to AGYW's vulnerability are rooted in deeply entrenched harmful social and gender norms and unequal power relations. To ensure the sustainability of DREAMS work, these social factors must be addressed through the contextual package of interventions. Additionally, USAID priorities include enhancing mentoring approaches, accelerating PrEP uptake and continuation, and continued capacity strengthening for local IPs to support maintenance transition. Mental health and psychosocial support are also gaining more traction and attention in DREAMS, and we anticipate this will be highlighted in COP guidance along with future training options. Lastly, I'd like to highlight a few publicly available resources in addition to the PEPFAR COP guidance, which includes the latest DREAMS priorities, as well as the latest MER 2.6 guidance updated this past September. So this includes the DREAMS portion, and now I can hand it over to Amelia Peltz, the team lead for the Gender and Sexual Diversity branch. Thank you.
Great, thanks so much, Kieran. Good morning and good afternoon to everyone. My name is Amelia Peltz. I'm the team lead and senior gender advisor of the Gender and Sexual Diversity branch in the Office of HIV/AIDS at USAID. I'm very pleased to join you today to share some technical updates for this program area. Next slide, please. So, as has been very well documented, gender inequality and gender-based violence are some of the most critical barriers to achieving HIV epidemic control. Globally, the data has shown us that around 35% of women on average experience intimate partner violence or non-partner sexual violence in their lifetime. And women who experience intimate partner violence are more likely to acquire HIV. The experience of GBV, particularly intimate partner violence, is associated with lower use of antiretroviral treatment, half the odds of self-reported ART adherence, and significantly worsened viral suppression. Gender-based violence has also been found to lower adherence to pre-exposure prophylaxis, or PrEP, a highly efficacious HIV prevention intervention. So in short, violence and inequality pose a substantial barrier to the effectiveness of HIV services and can undermine the uptake of and adherence to proven biomedical prevention and treatment options. Next slide, please. So this is a slide that helps to illustrate the vision that we have put forward around how addressing violence and inequality across the HIV cascade is essential to reaching PEPFAR's epidemic control goals. So in the same way that we address HIV across the clinical cascade, we also address GBV prevention, case identification, and response across the cascade with the goal of improving HIV-related outcomes as well as addressing violence. Next slide, please. And so this is a graphic that's an illustration of our strategic vision for advancing gender equality and preventing and responding to gender-based violence in the context of HIV. And it illustrates how our technical priorities support USAID's PEPFAR goals. So the first pillar of the strategy is to really grow the program. And this emphasizes the need to increase the identification, reach, and retention across the HIV prevention and clinical cascade, both of GBV survivors, of men and boys, people living with HIV, including those who don't know their HIV status. The second pillar emphasizes ensuring quality and promoting innovation in our programs and services in order to retain at-risk individuals, people living with HIV, and survivors of violence. This has become particularly important during the COVID time when many of the more traditional ways of delivering our services have not been available. So that innovation and thinking of new ways to reach people has become critically important. And finally, the third pillar focuses on really sustaining our investments in gender equality and GBV programs and services, and strengthening our partnerships in order to reduce structural inequalities that fuel violence and harmful gender norms. Next slide, please. So we do have the COP22 technical guidance that will be forthcoming in a few weeks. And there have been a few new sections to the guidance that I wanted to highlight today. I should say that the guidance is obviously still in draft form, but these are some of the directions that we're hoping to see in the COP22 guidance. The first is a new cross-cutting section on gender equality. And this is going to talk about the importance of addressing gender across the HIV prevention and clinical cascade, as well as touching on really key systems issues, including data, health information systems, and addressing human resources for health. We've also updated the gender-based violence section to reflect GBV prevention, case identification and response across the cascade, and really emphasizing the importance of integration into HIV services. And then finally, we've also tried to integrate language on gender equality and GBV into other sections of the COP guidance, which really helps to reinforce the language in those other two previous sections. So hopefully these are some of the changes that you are going to see in the COP guidance to better reflect the strategy and the importance of having this being an integral part of our response. I also wanted to mention, in case you haven't seen, that about 2 weeks ago now, the White House released the new national strategy on gender equality and equity. This is the first time the US government has released a whole of government strategy for addressing gender equality and equity. So I will put a link to that in the chat box so that you can all read it if you haven't had a chance to do so yet. Next slide, please. So I wanted to take a little bit of time this morning to talk a bit about measurement and program monitoring and program quality. I think many people on the call are aware that we have one MER indicator that measures GBV, that measures the number of people receiving post-GBV clinical care, which is based on the minimum package. Next slide, please. So we wanted to review what is in that minimum package. It's been defined by WHO normative guidance and PEPFAR, and this is all laid out in the indicator reference sheet. But the core package of services for someone who presents to a facility seeking care includes the treatment of injuries, rapid HIV testing, testing and screening, as well as presumptive treatment for sexually transmitted infections, the provision of first-line support, counseling. This isn't long-term mental health or psychosocial support counseling. This is that immediate first-line support known by the mnemonic lives, as well as referrals to other clinical and non-clinical services as indicated. In addition, for survivors of sexual violence, they should be offered post-exposure prophylaxis where clinically indicated if they present for services within 72 hours of an assault, as well for female survivors offered emergency contraception within 120 hours of an assault. So if we can go back to the previous slide, thanks. There's a couple of things we wanted to emphasize here. So when reporting on the indicator, it's essential that all of the services in the minimum package are available and in place at that site for that site to report. However, there are sites that cannot report on some of these. they shouldn't report on the indicator. Instead, using custom indicators to report on service delivery would be appropriate. It's also important to note that even though all of these services must be in place at a site to report on the indicator, a survivor does not need to accept all of these services. We never want to be in a situation where we are forcing or pressuring any survivor to take up a service that they don't want or are not ready to accept. As long as a client receives at least one service, then they can be counted under the indicator. So we wanted just to emphasize that. Next slide, please. So in FY21, so at the start of this fiscal year on October 1st, GenGBV shifted from an annual indicator to becoming a semi-annual indicator. So reported twice a year now in Q2 and Q4. So this is a change that we're very pleased with. However, we still encourage you all to report your data on a quarterly basis to your USAID AOR or COR because we do look at this data and we do like to monitor program performance on a quarterly basis, even if it's not being reported into datum. So we still encourage you to report in that way. Next slide, please. So there's a couple of disaggregates for the indicator. The indicator is disaggregated by sex, the finer age bands, the type of violence, be it sexual violence or physical or emotional violence, as well as post-exposure prophylaxis completion. And this is an important part to underscore. It's not the number of people initiated on PEP, it's the number of people who complete PEP. And so that's also a critically important part of this indicator, is that someone should only be counted under this disaggregate if they are able to complete that course of PEP. We do have some additional custom disaggregates that have been used to monitor different elements of the program, including ones that have been developed by our key populations partners and programs to disaggregate by key population type. Next slide, please. So speaking of custom indicators, we wanted to take another few minutes to share an example with you of how monitoring that PEP provision across the cascade is really important to monitor that quality of timely care to survivors. And so this is an example of how a service provider at a site can monitor that uptake and adherence to PEP. So it illustrates, this visual illustrates the program monitoring for PEP uptake in the case of sexual violence. And it particularly focuses in on gaps. Where are we losing people at different points along that PEP cascade? And some of these gaps might indicate a need to reach survivors sooner to ensure that they're aware of service eligibility and the time-sensitive nature of taking PEP after a case of assault. It could indicate that there is a PEP stockout at facility, or it could indicate perhaps a lack of provider awareness or an issue in the gap of the quality of that service. It might also indicate a gap in completion, and this is something that we also see frequently, in that survivors don't return for their follow-up appointment for follow-up HIV testing, and therefore we don't have any monitoring records, and we have no way of confirming that their course of treatment was completed. So we would encourage you to also look at tracking this kind of data across the PEP cascade, recognizing how critical it is as an HIV prevention service for survivors of violence. Next slide, please. So we also just wanted to underscore what is not counted in this indicator. Understanding what is counted is just as important as understanding what's not counted. So because this is a clinical indicator, it doesn't count any of the really good work that's being done at the community level on prevention and norms change activities, or any kind of non-clinical response, which might include case management or shelter, longer-term psychosocial support, or education. In this case, again, it's those custom indicators are so critical to measure and monitor all of the good work that's being done on prevention. Kiernan spoke about this a little bit in the context of DREAMS on the gender norms indicator. But we are happy to help and support you in the development of custom indicators and monitoring and tracking them to really give a full picture of all the good work that you're doing. Next slide, please. So speaking of results, we wanted to share a little bit of data. This is your data that's been reported. This is a snapshot that shows between FY16 and FY21, our Gen GBV results to targets. And this is just for our local partners. This doesn't capture the full breadth and depth of all of our results, but we really wanted to highlight your data here to show you all the work that's been done. And so we're really excited to see that the overall volume of results does continue to grow. Next slide, please. And this is just a slightly different view of the data. This is, again, just results from all of our local partners. And this shows you some of our results by country. So again, as you can see, we are making really good progress towards growing that program, that first pillar of our strategy. And really, it represents such an incredible effort by all of our local partners and many of you who are on the call today. Next slide. So finally, just to close out, I've got about 3 slides here. I just wanted to show you, we can just go through those very quickly. There are some technical resources that we wanted to share with you. It includes USAID and PEPFAR guidance. It includes WHO normative guidance and clinical tools, as you see here. Next slide, please. And we also have examples of programmatic practices, good practices, examples of guidance for working with special populations, including key populations. And I believe on the next slide is we have all of our resources on violence against children, which Colette referenced earlier. So we have resources here from For Children, from Together for Girls, and from AIDS Free, as well as WHO on addressing violence against children. Next slide, please. Great, and with that, I will pass the microphone over to Elizabeth Berard for updates on youth programming.
Thanks, Amelia, and good morning, good afternoon, and good evening to all of our colleagues. It's great to have all of you with us and look forward to the forthcoming discussion. Just as I am Elizabeth Berard, and I'm the Youth Branch Chief in the Office of HIV. So it's great to virtually meet and work with all of you today. I am going to ask a couple of questions of you all. So I do want to point you to the reactions button at the bottom of the screen. And in the questions that I ask, if you all are familiar or are working in this area, I'm going to ask you to give me a thumbs up or a clap or something like that. So just to point you to that button so that you're ready to rock and roll. Okay, next slide, please. Okay, so yesterday, it seems like a few days ago, but it was only yesterday when we talked a little bit, Clint Kavanagh, our office director, shared with you all that USAID is implementing the HIV Optimization Plan. And he showed the 5 pathways. Well, pathway 2 is actually on adolescent and youth resilience. We recognize that the majority of the population in the countries that we are working in, the majority are actually under the age of 30. In the case of Africa, the majority of the population, or about 70%, is under the age of 30. So we know we need to be doing more for adolescents and youth within our PEPFAR programming. So this is an overview of Pathway 2, just to say that the pathway is still under development, but it gives you a quick sneak peek anyway. And the overarching principle that I want to point out here is on youth engagement. So we recognize that in order to accomplish our programming, we need to be thinking about more of how to better engage youth in our programming. So these 3 results objectives are the principal areas that we're interested in prioritizing moving forward in terms of increasing the uptake of health services that directly reduce the impact of HIV on adolescents and youth, the The second result, which has actually changed even since these slides were finalized, includes targeted adolescent youth receive educational and employment assistance that increase the probability of remaining HIV-free and or virally suppressed. And then the third objective area is national program level data systems include individual tracking of adolescents and youth, including key populations, to better monitor access and uptake of services critical for HIV epidemic control. Next slide, please. So this is the first area I'm going to ask for all of your engagement. This is USAID's definition to positive youth development. I'd like to ask all of you if you can give me a thumbs up or a clap if you have heard of positive youth development in the past. Okay, I'm seeing a handful, which is great. I'm sure more folks are trying to find the icon, so I'll just continue here. But I do want to just point out that positive youth development is USAID's overarching youth development approach. And we've been working with this methodology, which is recognizes that youth need a multi-pronged approach for the best outcomes. We've been working with this formally and calling it positive youth development since 2015. Next slide, please. So positive youth development programs recognize that youth's inherent rights and results in youth who have the hard and soft skills or assets, the ability to leverage those assets or agency, the ability to contribute to positive contributions for themselves and their community, which is in the contribution circle. And then they have an enabling environment that supports them. We recognize that all of these 4 different domains are critical for healthy, productive, and engaged youth. So just to say that within PEPFAR, while we often implement positive youth development programming, whether it is in DREAMS programming or in our HIV treatment programming with support groups and working with healthcare providers and community members, while we often implement positive youth development, many times within PEPFAR and even within the health space, we don't call it positive youth development. We don't recognize it as such. So I just wanted to pull that out today. Next slide, please. And one of the very important parts of positive youth development is that contribution element or meaningful youth engagement. Now, if we pull it back and talk more about PEPFAR here, within PEPFAR, we talk about the importance of client-centered care. And one of the critical ways to ensure that we get feedback from youth regarding the care that they're receiving is by promoting meaningful youth engagement. So evidence has shown that it's beneficial to engage youth in all phases of a program cycle. Involving youth in design, implementation, monitoring, and evaluation can lead to more effective and appropriate programming by improving impact, retention, and sustainability. In addition, including them in the data collection process can increase their agency while also ensuring the validity of the data collected. Through meaningful youth engagement, youth are empowered to provide a vital role in their own development, as well as that of their communities. And within the programming context, active participation in the decision-making processes in the design, provision, and delivery of services can make sure that our programs are best meeting their needs. So recognizing the importance of meaningful youth engagement, I'm going to share several good examples of meaningful youth engagement in the next few slides. But before I do that, I'm going to ask you again to use those reaction icons and ask you all if you integrate some form of meaningful youth engagement in your programs. So again, a thumbs up or a smiley face or applause if you incorporate some sort of meaningful youth engagement. Okay, gives us an idea, and that's helpful. Thank you very much. Next slide, please. Okay, so, okay, this is one example that was shared with us by our colleagues at PSI's Adolescent 360 project. And this is a family planning, sexual reproductive health example, but I think it's still meaningful in our case. So in the blue boxes, you can see some of our initial traditional kind of messaging around getting pregnant and using contraceptives. So when you become sexually active, use family planning so you can finish school and achieve your dreams. Adolescent 360, you know, they wanted to really make sure that these messages were hitting home. And so they designed a human-centered design approach in which young people were engaged to provide meaningful feedback on what was their own experience. So in this case, through this HCD approach, they discovered that instead of you thinking that when you become sexually active, they were actually thinking of, you know, I'm not sexually active, he's having sex with me. So in the first case here of this box, the engaged youth didn't want to admit necessarily to being sexually active. In some cases, there were gender-specific messages that came through that made the man the decision maker. Can someone press down and go to the next, click down one for interaction? Thank you. In the second box, the messages reflected some of the myths that were coming through, but also some of the desires of young women. In our case, we could insert something like, I won't get HIV here as well. Next. Thank you. And here in this box, this recognizes and reinforces the actual realities in terms of the barriers and challenges that young people are coming up against. Next slide, or this one, thank you. And then in this box, we also recognize that we need to better understand that being a mom may be a critical part of a young woman's desires. One more click. And then just to reinforce or just to note that in terms of this, I am helping her, this was the initial perspective that Adolescent 360 and many of our programs have when we don't necessarily engage youth and ensure that we are meeting her specific needs by soliciting and getting input and feedback and support from the design. So through this HCD process, Adolescent 360 was able to move forward with a project design thinking of the work more as a partnership with young people. Next slide. Okay, this is an example of a current program or current activity that's being implemented by USAID in a number of countries. And this is the HIV Prevention Ambassador Training Toolkit and package. This was actually designed for the community and community-based organizations and other groups to train HIV prevention ambassadors with the idea and goal of promoting meaningful engagement of communities, PrEP users, and potential PrEP users in the rollout of PrEP for HIV prevention. So in this case, and the reason I'm profiling it here, some of these HIV prevention ambassadors are adolescent girls and young women themselves. So through these interactive activities and discussion and action planning, the training prepares the ambassadors to share information with their peers about oral PrEP. Additionally, the ambassadors gain various different skills that help bolster their agency and their belief that they can use these skills in the world out there. So additionally, the HIV Prevention Ambassador Toolkit includes one-page handouts and worksheets such that the trained ambassadors can take these materials back to their community and support and conduct peer support, community discussions, and other activities. Next slide. This is the last example I have here. And so this is an example that was shared by Elizabeth Glaser Pediatric AIDS Foundation, in which AGPAF really recognizes and puts into action their understanding of the need for meaningful participation of youth as really critical to the future success of their programs. So in this case, the Elizabeth Glaser Pediatric AIDS Foundation, or AGPAF, developed the KAYA model, which is a committee of African youth advisors that supports and advises their senior leadership team on what is going on for youth in the programs and countries that AGPAF is implementing in. So this is a structured mechanism to work across the 11 countries AGPAF is working in which 2 youth from each country comes forward and is part of this KAYA group. So the group is designed to help teams to collaborate with youth in real time with their fresh ideas and understanding. And it's reciprocally beneficial to also strengthening the assets and agency of young people themselves. So KAYA members are ages 15 to 29, many of them living with HIV, and they are selected by their country team members. And then they have a mentor or a focal person at each AGPAF office in country to support the young people. Next slide. And this is an example from KAYA in terms of one of the tools that they deliver, that they recognize that there was a gap in terms of treatment literacy. And KAYA members actually came together and developed this treatment literacy cartoon guide, in which they piloted the guide, and the guide is now used currently in terms of peer support activities provided by these KAYA members and other AL/HIV peer supporters, and it has been thoroughly integrated into their programming. So that is just an example of where youth identified a need and they move forward to carry this to fruition. Next slide. So that's the end of my presentation. And the last request I have of you is, if in the chat while we begin to talk, if you do have examples of meaningful engagement of youth that you are able to provide in the chat, I'd be very, very interested in seeing what you all are doing. So thanks so much.
Great. Thank you so much for all our presenters. And I'm going to look through some of the questions we have now and put them out to you all. One of our first questions came in and asking about what key challenges have you encountered and how have you addressed these to achieve your targets that we can learn from. This was the Namibia Adherence and Retention Program for the intervention. And maybe while we're thinking about that one, if Dennis, who put that question in, if you're willing to specify in what technical area you'd like that response. I think this was coming in at the beginning for Colette. Sorry, yeah. For the partnership between care and treatment partners and OVC partners in South Africa, they're limited by the Department of Health when it comes to sharing of patient level data, making it difficult for OVC partners to know which of their beneficiaries are virally not suppressed, so as to provide additional adherence support to them. How are partners in other countries addressing this if they have similar restrictions on data sharing? Colette, I don't know if you know, or it could be a question for others as well.
Yeah, thanks, Debbie, and thanks, Maria Habo, for the question. It's a very good one, and it's been certainly a challenge as we have really, you know, moved the OVC program to more closely wrap around clinical services and try to share data where we can to most accurately track, you know, both track things like viral load suppression and the HIV outcomes we're after, but also, you know, assist our targeting and trying to offer OVC services to kind of the most vulnerable, those that are failing treatment, you know, HIV exposed infants, things like that. I know we have a number of other partners and folks in the session here who come from different country experiences and may have more to share on this from their context. So I encourage you to add if you think there's anything useful to mention here. But I will just say, I think in general, what we have found is that having, you know, it has taken repeated meetings and advocacy with our health colleagues, depending on the context. Sometimes there's been a preference to do this at site or facility level or at the national level. But the collaboration has been really important to help, you know, our facility-based colleagues and those that work on that programming understand what it is that the OVC program can kind of offer in terms of, you know, these services that we support, that we provide to children and families will help them achieve outcomes thereafter, right? As we are seeing in some of the data I mentioned around improved viral load suppression rates, for example. And I know that in some countries they have had success, you know, kind of explaining this. And then there's just more incentive, right, if you will, to work out data sharing agreements or, you know, at the very least, more details of like the MOUs between facility and community partners on how that might work. I'll just also mention we have some excellent colleagues within OHA from our health informatics team that have been really helping us think through this as well, because honestly, even when there is, you know, willingness, sometimes just the logistics of the interoperability of the systems that we use for OVC programming and, you know, clinical programming and DHIS systems is challenging. So we have some wonderful colleagues who've been helping us think through that in different country contexts and work out, you know, as we try to continue to improve our electronic case management systems that monitor our OVC programming, helping us find ways to, you know, enable interoperability so that we can, in a confidential way, in an appropriate way for, you know, information for those who need to know, since those are often some of the concerns, you know, find ways to have those systems talk, and so that we can have the data we need to help support some of those kids in need of additional services from the OVC program. I hope that helps a bit. And then again, as I said, please, you know, and any others who are in the session here who maybe have some more specific country experience with this, please add. Thanks.
Yeah, and I'm seeing from Wilson saying that you've set up an MOU with health facilities for this kind of facilitation of data sharing and compliance on confidentiality. That's great. Wilson, you're noting in Rwanda. Yeah, great. Any other country examples that might be interesting for people to note in the chat? And then please, it could be a nice cross-country sharing too, if people are able to follow up if you want to hear more between countries about how this is done. It may be something also for our OVC and data teams in our Office of HIV/AIDS to think about putting some tips together or sharing some country models on if it's an issue that many are dealing with. There was another question that came in the chat from Sheila saying that these presentations, these images make me think of a question for reflection. What approach to apply to young people who have no perspectives for the future because they live in a context that offers them nothing? Furthermore, the role of family and other institutions responsible for the individual socialization have lost weight, or at least do not exercise this influence in the education of young people. So I don't know who wants to take this one, maybe Elizabeth, but what do you think about how we can support these very vulnerable youth and young people when they're living in a context without a lot of support for them?
Thanks, Debbie. I think, honestly, one of the ways we can support these young people is to engage these young people in our programs. It's really easy, I know the work that we're doing is not easy in terms of implementation, but it is easier to design programs on our own and just roll them out. You know, I think we've done this for a number of years. It sounds like Colette was keeping track in terms of the number of you that felt like you were doing meaningful youth engagement in your program. And roughly 7 or 8 of you thought you were doing meaningful youth engagement activities in your current programming. So that's not that many, especially when we're talking about 75 to 80 of us on this call. You know, I think that when we engage young people and better understand where they are coming from and what their actual experiences and perspectives and needs, and recognize also that young people have so much energy and innovation and creativity to bring to bear, that they may just be chomping at the bit to have their voice heard, to be heard. I heard yesterday in a presentation on another human-centered design activity with adolescent girls and young women in Nigeria under the RISE project, again, doing work in PrEP. The young women, the messages coming out of that HCD work from those young women was that the young women wanted to be in command of their lives. They wanted to be in control. And so, you know, when we stop and really engage young people and hear their experiences and the kinds of messages that will best resonate with them, and engage young people as leaders in implementing activities, designing, monitoring, and evaluation. You know, I also think in terms of this point, in terms of the role of families and other institutions that are really kind of disappointed or have left youth out or not supporting youth, that's absolutely true. But in terms of the enabling environment, there are other, other mentors and other individuals within the community that may be sought after, whether formally or informally. And it's only through the engagement of young people will we learn about such mentorships, such relationships that are the realities of the young people that we're supporting. Thanks.
Thanks, Elizabeth. Great points. And I see Segun also added in the chat that in Nigeria, they've had some good collaborations on data sharing. So another potential resource to follow up with if you want to learn more about how to facilitate that data sharing between government facilities and these programs. I'm seeing another question or comment more, just I'll read out. In addition, a key expected outcome for PYD beyond improved health is resilience. This approach can change young people's outlook and hope for the future. So thinking about really strengthening that resilience is critical. And the need to empower and engage young people to lead discussions, interventions, and support their peers, really giving them the leadership in these roles. One question to put out there for everyone, I know that we're interested to hear too, is Does anyone have experiences in how you've responded to increases in gender-based violence or violence against children during COVID, and how you may have adapted your services to reach survivors? We know that this is a major issue and maybe harder to even have visibility on, as we've been in different phases of lockdown. But anybody have any comments on that they could share in the chat or share? And thanks, David, for sharing that in Nigeria, you've taken a step of engaging young people as caseworkers, and that's really helped change their the behaviors as their peers, which is a really great model of employing the youth to be part of your programs. Anyone have any thoughts on the gender-based violence and how that's increased over this period of COVID? And Amelia, I don't know if you want to add in any thoughts or perspective on that.
Thanks, Debbie. Yeah, it would be great to hear from you about your experiences as partners delivering services. What you have seen during this period of COVID in terms of increases in violence against children, gender-based violence, and what you've tried to do to modify and adapt services to reach people that have been harder to reach due to lockdowns or lack of transportation or restrictions in service provision. So it would be great to hear from you on that and to have a dialogue amongst partners on that.
And while people are thinking on that question and hopefully putting some thoughts into the chat, we're also curious to see what you all have to say about your greatest challenges in your current and future programming in this next year of implementation in these different technical areas. What are the top things you struggle with, your top struggles for implementation with OVC programs or in your gender programming or youth programming or work with adolescent girls and young women? Be great to hear. And I see Nakofa Scholastica talking about establishing partnerships and really working through community, traditional LGAs and religious leaders to address GBV at the community level, and working with your treatment advocates with direct linkages to health facilities to connect people to gender desks to get support. That sounds great. And of course, in COVID, some of these community and religious leaders and others are still very active. So that's a great way to reach people for sure. And Hilmila, I'm seeing you use law enforcement agents and agency and religious leaders also to reach out to survivors of GBV or victims of GBV. That's right, another great way to connect with those who may be seeing people come in having experienced GBV. Segun, I see you noting measurement of gender norms. Maybe you could expand on what that means exactly. How have you been measuring gender norms? It'd be interesting to hear. And Wilson, for the case of GBV that increased during COVID, you've connected with media houses, radio, TV, broadcasting to raise awareness, and at the same time, engaging GBV communities at the committees at the community level. Right, interesting. So another approach kind of going through radio where people are still hopefully listening in, even if they're in their homes and not out and about as much, that you have a way of connecting through media. That's a great idea as well. Amelia, any follow up on that or thoughts?
Yeah, thanks very much. It's great to hear about these efforts, and certainly engaging with, radio and TV to raise awareness, I think is important, and also letting communities know about the availability of services, where they are, how to reach them, and their operating times is also really important. Certainly engaging with community and religious leaders is great, and would love to hear more about the measurement of gender norms. This is something that also is a really interesting way to understand the larger impacts that our programs are having on norms that really sanction and condone inequality and violence. And so it would be great to hear more about that, how you're doing it, and what you've seen. Thank you.
Yeah, thanks. I really want to share experiences from others, best practice from other countries on measurement of gender norms. We have a particular way of doing that. However, it's nice to have some other best practices from other countries, how they actually go about that. Over.
Yeah, Amelia, I don't know if you have examples of other countries that have done measurement of gender norms, any best practices, or others, please chime in.
Mm-hmm. Sure, that's a great question. Thank you. I mean, we have programmatic indicators that measure the number of individuals who would participate in group or community-based activities that are meant to shift gender and social norms. Another way that is possible to measure is there have been a lot of sort of well-established scales and indicators of measurement, certainly around attitudes, beliefs, behaviors. Many of the questions that are on population level surveys, such as the Demographic and Health Survey, looking at some of the modules on domestic violence or women's empowerment, those also have really nice and well-established questions that can be used to measure and monitor these kinds of shifts. So would be happy to follow up and provide some additional resources on that at the conclusion of this session, but certainly looking at both programmatic indicators as well as those larger population level indicators do present opportunities to understand how there are shifts and changes in norms and attitudes and behaviors. I'll also say one of the things that we have learned and that we have seen from our programs is that while we know that harmful norms can really be an impediment to our programming, we never necessarily want to assume that we know which norms are the impediments to our programming. And so having a much more nuanced understanding of the beliefs that are held and those that really kind of reinforce ideas around the use and acceptability of violence or inequality between people. Those are really important nuances to understand, because then we are in a better position to address those specifically in our programming, in our messages, in our communication, and in our ways of interacting and engaging with different parts of the population. So it's really worth taking a moment to understand those, just to ensure that our engagements are really grounded in that reality, and so that we understand what specific things are we trying to change and why. So thanks so much for putting that in the chat and prompting the discussion. I think it's really interesting.
Yeah, and I see some more chats coming in about how people have worked with police or others, community members, reviewed the laws and really educated people about the laws and even local kind of adaptations of laws. So that's great to see. I think it looks like everybody's been doing something in this area or thinking about it, as it's obviously impacting many, many people that we're working with. I wanted to go back to the question on, what do you think your biggest challenge is as we think ahead to this year of implementation? We're just into our PEPFAR year, a month in basically for implementing our PEPFAR programs for this fiscal year ahead. And it'd be great to hear, in the OVC realm, or in the working with and the DREAMS programming, or any of the youth programming, what do you see as your greatest challenge in this year ahead? And if people want to raise their hand and come off mute, we can also do that. So we hear more voices than just me. We know we're always very fixated on hitting our PEPFAR targets and have a lot of challenges sometimes in doing that. That's always one area I know people are concerned about, but what for you all seem like the biggest challenge ahead? Yeah, Moses, go ahead.
Yeah, I know we still have COVID around in our communities. And I'm sure there's a lot that is happening around vaccine, and it's also negative impact as there's resistance on the vaccines as much. And then the rolling out of vaccines to that age where they are below ages. And I'm sure where we are hit a lot is part of the southern part of the world, and how to make sure that we overcome that and have those spaces for girls, safe spaces, still becomes a challenge. So I think for me, this is one of those greatest challenges. I know we were trying our best, but as long as COVID is still around, and also these other myths that is around them, and the resources to ensure that our girls have vaccine and they can have confidence about the communities. That's challenge for DREAMS programs.
Yeah, thank you. And I see that kind of echoed in our chat. Admin saying getting people vaccinated so that we can work without stopping and reaching the right children with services. So, I mean, I think for all of us, COVID is at the forefront of our thinking and impacting all of our work. I see Scholastica saying limited resources to effectively address GBV systemic challenge. Ooh, I lost it as the chat went up. And sometimes that this is out of your scope of work, but yet really a critical area. Anyone else want to take themselves off mute and say your comment? Looking to see if I see any hands raised. And I'll read through what we have in the chat, but please feel free to also take yourself off mute and add in your thoughts. I'm seeing AGYW have high expectations on material support and biomedical and prevention interventions. Maybe if you can elaborate a little bit on that, meaning that there is expectation that we can't meet. Is that what you're getting at? Another challenge. Oh, go ahead. Yes.
Thank you very much for giving me the opportunity. I was actually in a meeting. Workout. Yeah, thank you very much for giving me the opportunity to elaborate on it. In our project, we provide the DREAMS program, all the 4 core packages, but the AGYW will value most the economic strengthening, where they expect to be given to start businesses, or probably
You're cutting out a little bit for me. I'm having a hard time hearing.
Be supporting on the vision, like the curriculum, the CBO.
I'm sorry, I didn't hear most of what you said, although I heard sort of challenges in being able to provide business and linkage. Sorry, I couldn't quite hear. Maybe you can elaborate in the chat. And I saw another comment come in about COVID affecting businesses and education. So the linkage to social economic private partnerships was more difficult as the businesses. Linkage for AGYW to employment and vocational training and high school spaces are limited. So COVID's impact on kind of opportunities for jobs and education has also been a struggle. We have just a few minutes left, and if anyone wants to add in anything else, or I will turn it over to our presenters if they are willing to say one last word across each of them and wrap us up. Colette, over to you if you want to respond to any of the chat or just say any closing comments.
Yeah, I guess just in closing, I mean, first of all, thank you for all the chat contributions. It's so valuable to hear from all of you, understand what you're grappling with a bit, and of course, like share promising practices from other countries. So it's great to have this opportunity to hear from you. And I want to acknowledge too, for orphans and vulnerable children, you know, what a critical role local partners play in implementation of this programming. And I think, you know, as Debbie from the local partner team can probably attest, we've always had amazing representation of OVC partners and kind of the number of local partners that we have as an office and that we are supporting and continue to support. And you know, your role in the community, your knowledge of community-based work, and you know, the insight you bring to addressing some of these challenges that come up is so incredibly valuable, and we realize how difficult it is. And I think for OVC specifically, the way that we've really asked our OVC programs to link with clinical programming more, as noted in our in what we've discussed here, there are so many challenges to it, but I think that, you know, because of the great work you do, it's really helped in that advocacy to show the value of this programming, how it helps us all achieve the HIV outcomes we're after, as well as, you know, child well-being outcomes, and just some of the broader things that I know all of us who work across these program areas are really interested in for young people and their families. So just a huge thank you for your work. It's been great to be part of this group today, and yeah, I will let others chime in as well. Thanks, Debbie.
Kiernan or Elizabeth or Amelia, go ahead.
Sure, thank you. Yeah, I can go next. Yeah, so Kate actually touched on what I was gonna mention about the economic strengthening component. And we've kind of just seen over this past fiscal year's data, reaching the 20 to 24-year-old age band in DREAMS has seemed to be especially challenging, just given that age band and maybe moving away from a DREAMS site or just having hesitancy to complete the program. And really one of the ways that we've tried to increase completion rates has been with this economic strengthening program. So there is, you know, just continued emphasis on strong partnerships, even with the private sector, and supporting wage employment there, or even supporting entrepreneurship pathways. And just kind of to note that PEPFAR is dedicated to creating an equitable workforce, and that DREAMS participants could even be considered and trained for health systems positions within PEPFAR. And even within, you know, broader health organizations as community health workers, M&E, and lab systems, survey data collectors, and other health systems work. So just really excited about this. We've even had some engagement with the YP2LE business, entrepreneurship and private sector engagement community of practice, and have showcased some of our developers of some of the comprehensive economic strengthening packages. So really just looking excited, you know, looking forward to this economic strengthening in the coming fiscal year. Thank you.
Thanks, Kiernan. Amelia, over to you.
Sure, just to thank all of our local partners. You know, when we look at our results, almost 60% of our global results are coming from local partners, which is just an incredible effort that you all are making. And so really want to acknowledge and thank you for the hard work. Doing GBV and VAC services is extremely difficult, and we know how hard it is, and just want to acknowledge that. We're also really interested in continuing our dialogue with you. And because as we think about the work we're doing, we really want to build systems and services that are sustainable for the long run. So we're really keen to hear more from you about what do you see is needed to make this happen, and how can we partner with you to think about that sustainability? It's, you know, not just about, you know, financial resources, but technical training, on-the-job mentoring, supportive supervision, policy shifts, engagements with other parts of the government. We really do want to hear from you and get your thoughts on what needs to happen in order to make the investments that we're making now sustained over the long term. So please don't hesitate to reach out to us. We would love to continue the conversation with you. Thank you all.
And Debbie, maybe I'll just, I know we are at time. So just to say that USAID and the Office of HIV, we are really putting forward recognizing adolescents and youth resilience as a critical pathway for PEPFAR and USAID to support epidemic control. And so we are really talking about positive youth development approaches, and more specifically, opportunities to meaningfully engage youth in our programs. So this is something that I know you're going to hear a lot more about in the days, weeks, and months to come. But, you know, thank you very much for the work that you're doing, and look forward to further collaborations. Thank you.
Thank you all. Thanks to our presenters and everyone